में हाँ ठीक है इसमें अभी तो है मैं अभी बंद कर देता हूँ हाँ
Assalamualaikum. Thank you very much for the very kind invite to all the organizers, Ali, Faisal Bhai, and Batsab. This is an excellent program, and it's an absolute privilege to be talking to you. And thank you very much for your time on Saturday. So I'll be talking in next few minutes about the GI cancers and the multimodal management, along with some new developments in the field. So I'd hope that some of the concepts about multimodal management would be applicable to the broader oncology community rather than just GI cancers. These are my disclosures. So what I wanted to focus on was rather than just talking about the developments in the field, I wanted to challenge the concept of the traditional MDT setup. Although MDT setup is critical to decision making, but the evidence-based medicine and how we approach an individual patient probably has changed over a period of time. So there are, whenever I start a talk, I would like to, because there are so many slides, I would like people to focus on 3 or 4 take-home messages from the talk. So the 4 things that I would concentrate on would be multimodal treatment basic principles, then rectal cancer, where there has been new developments in the field, the role of circulating tumor DNA and its applications, which I would imagine would be applicable to most other fields of oncology as well. And then more specifically, colorectal liver metastases, where is the evidence, where it stands, and how we extrapolate the data. All of those are critically important concepts. So, coming back to the initial concept of multimodal management and personalized medicine, the question I would like to ask and people to think about is it really complementary or incompatible? And it will become hopefully clear soon why I'm asking this question. So, what is traditional evidence based medicine? We all know evidence-based medicine is where we have trial data. Traditionally, we rely on phase 3 trial data to determine what should be the best guidance for management of our patients. And indeed, that is important because we need to have a framework of what we are following and how we are treating our patients within a certain guided manner. There are different guidelines out, but what is the complexity? So this figure, which actually is from more than a decade ago, some of my colleagues, which I work very closely with, Marco Gerlinger and Timothy Yap and Charlie Swanton, they proposed this model of intratumoral heterogeneity. So what that means is that there was a traditional concept that the primary actually determines how the secondaries would behave. However, they showed that when they biopsied, this paper I'm sure most of you are familiar with, made it to New England Journal of Medicine, despite the fact that there were only 4 patients with whole exome sequencing from multiple tumor sites, which were in that paper. But what that showed was that each secondary could start behaving as a primary with a new molecular profile. In other words, it was independent of the primary and it could behave in an entirely different fashion compared to the primary. And that poses a challenge. If you think about it, what we rely upon in decision making is a simple single tumor biopsy, but this may not represent the whole molecular landscape of the disease. At the time when Charlie Swanton proposed this idea, it was not very popular in the clinical community because we still had very limited treatment options. If you think about 12 years ago, most of the tumors we were managing with different traditional forms of chemotherapy. Moving fast forward, now we know that in a lot of tumors you're using immunotherapy, you're using targeted therapies, and that is driven by molecular landscape. So does it not pose a challenge that when we are sitting in the MDT, we base our decisions on simplistic facts like this patient has colorectal adenocarcinoma T4N1. Should we give treatment or should we not offer treatment? But is it not that, or particularly when it is metastatic disease, we say, okay, this is liver metastatic disease or lung metastatic disease or multi-site metastatic disease, but we are actually relying on a single tumor biopsy, which is one of the limitations. So that is for you to just think about what the question I've asked, and then later on I'll show you how the extrapolation of the data in some cases within the context of a very good running MDT is important. So now I'm coming more specifically to colorectal cancer, where we have some developments in the field. So keep in mind, we are switching from one theme to other. The overwhelming theme is how the patients should be treated within the context of the evidence and within a good multidisciplinary team. Now, in terms of the total neoadjuvant treatment in rectal cancer, we know that the rectal cancer management has transformed over the years. And here I'm not going to focus on MSI high or MMR deficient tumors because that in itself will take an hour to go through the evidence. I'll just comment on it. We know that in that field where patients are diagnosed with MMR deficient tumors or MSI high tumors, and that again is applicable not just to the colorectal cancers but all GI cancers, and perhaps the field will expand once we start checking MMR status of the tumors in other broader solid malignancies as well. Any tumor type, if you have MMR deficiency, you must think about immunotherapy, whether it is early stage disease or late stage disease. In the late stage disease, evidence is now absolutely clear, so there is no shadow of doubt about it. In early stage disease, there are a number of clinical trials, including a trial that we are running at UCLH and was presented by my colleague Kai-Kin Xu, called NeoPrism study, and it showed that if you offer neoadjuvant or almost curative treatments in the form of immunotherapy to the patients with MMR deficient disease, you're almost guaranteed to receive 100% response, or not just radiological but pathological response as well. But that field is evolving, and I'm not going to touch that. So I'm more going to focus on the vast majority of our patients, which is 85% of our patients who have no MMR deficiency, so MMR normal disease. So if we look at the management of locally advanced rectal cancer, so you'll recall that rectal cancer is slightly different entity compared to colon cancer. And I say recall that because some people may not be treating colorectal cancer. Even for them, those who have been through their training would remember that colon cancer generally has a tendency to metastasize to other organs. So stage 4 disease is more common. Rectal cancer has more propensity to locally reoccur. So therefore, the two tumors have been managed in a slightly different manner. Secondly, rectal cancers tend to be radiosensitive. So there's a lot more role of radiotherapy in rectal cancers compared to colon cancers. So the management has improved over the years, but what you see is that in T4A or T4B disease with high nodal involvement, the survival outcomes are still not fabulous. So there's a lot that needs to happen in order to improve the outcomes of these patients. But what we see is that over the last 3 decades, outcome of the cancer has improved, and that is attributed to improved surgical techniques. That is one of the most critically important aspects of that. Then multidisciplinary treatment, which is very important, and then widespread screening, obviously, early diagnosis, and more importantly, neoadjuvant treatment. Neoadjuvant treatment and multidisciplinary management are linked to each other, and we'll get the feel of that in a minute. So the question is, how can we better stratify the patient? Because there are lots of clinical trials which are looking at the evidence of total neoadjuvant therapy, and you'll see that there are different sequences which could be adopted. But let's examine the evolution of the rectal adenocarcinoma and how the outcomes have changed and what trial evidence is available. So you'll see that 3 decades ago, the TME was a standard treatment approach. Then we started using radiotherapy, short course, long course, but all the evolution until 2014 onwards, where lots of new trials developed, was actually different types of radiotherapy was incorporated into the management, and that clearly improved the outcomes. But more recently, total neoadjuvant treatment has been examined, which means that you have a sequence of either chemotherapy first or radiotherapy first and chemotherapy. Within the radiotherapy, you have 2 different approaches with short course or long course. But one of the most important studies, whilst there are a number of studies which have been published and the data have been presented, to me, one of the most important studies is prospect study, even though there is a criticism of the inclusion criteria in the prospect study. But I think the concept is really attractive because what they did was they offered neoadjuvant chemotherapy, 6 cycles of Folfox to this patient population with locally advanced rectal cancer, restaged it at that point, and if there was more than 20% response, they proceeded with surgery, sparing the patients from pelvic chemoradiotherapy, which is a unique concept because generally speaking, in high risk patient population, it is well established that the best outcomes are achieved by both, well, complete total neoadjuvant approach, including chemotherapy and chemoradiotherapy. So what this trial showed was that there was minimal or no difference in the outcomes in disease-free survival. In the overall survival, you can see mirroring, overlapping curves. But more importantly, you wouldn't see actually any difference in the local recurrence rates as well with Folfox group versus chemoradiotherapy group, which is really important and revealing. Because if you recall in the beginning, I said that one of the most important aspects considered for rectal cancer was the high rate of local relapse. Hence the reason radiotherapy has always been the attractive avenue exploited in this arena. However, what we see is that if the patients have a fantastic response to neoadjuvant chemotherapy, you can actually end up with equally good outcomes by sparing
जब डॉलरों की
radiotherapy.
गेम देखता हूँ ना मैं, जो कॉलेज की दिन उठ जाता है जब डॉलरों वाली गेम नहीं चल रही होती, फिर उस कॉलेज ही पढ़ना शुरू कर देता हूँ।
in, in a proportion of patients.
पार्टिसिपेंट कितने
Having said that, I think it's important
हैं?
to take each patient individually and think about what is the best treatment option for that patient. So, what are the options? You have total neoadjuvant treatment, so you can have chemoradiation, chemotherapy, surgery, chemotherapy, chemoradiation, or surgery. And when you look at different trials, they have in fact examined different ways of asking the same question. So you have the Rapido study, the very popular study, which looked at the standard of care arm, which is as we normally do, chemoradiotherapy, break, surgery, and then adjuvant chemotherapy. And then in the other arm, they had, in the experimental arm, they had actually the short course of radiotherapy, then chemotherapy, and then surgery. And again, what we see is that there was very minimal difference in the outcomes. More importantly, the overall survival curves overlap each other. Prodigy 23 trial is also an important study which was recently reported. And this again had more intensified form of chemotherapy with FOLFIRINOX. So all 3 drugs combined together. But look at the inclusion criteria of all these studies. So I'm not dissecting too much into it in the interest of time, but important factors are CT3, CT4 disease, any nodal involvement, extramural venous invasion, or CRM threatened. Of those, I think CRM threatening is probably the most important factor, which is consistent in almost all of these trials. So you go with very high intense dose of chemotherapy, followed by chemoradiotherapy, then TME, and then further chemotherapy. And again, what you see is that the overall survival, if at all, was in favor of neoadjuvant approach compared to the standard of care approach, although not a remarkable difference. So I think what it tells us is, again, Oprah trial, similar thing. So I just want you to concentrate on the curves. And what you see is that even in Oprah trial, the curves overlap each other. So there's no real difference in the distant metastatic free survival, local recurrence free survival. So all parameters that you can think about, overwhelmingly, they match each other. So there's no real difference. So what it tells you is, so now just to summarize what we've learned so far, that for patients who have any high risk factors, you must consider total neoadjuvant approach. Within that total neoadjuvant approach, you can consider any approach, chemotherapy first or chemoradiotherapy afterwards, or chemoradiotherapy first and chemotherapy afterwards. I'll come to it in a second, what I feel is a more favorable way of doing it. But one thing which is also in development is circulating tumor DNA. Because remember, in rectal cancer management, you have 2 issues, or not issues, but 2 questions. So one question is which approach to take first, total within the total neoadjuvant approach. I feel that most of the MDTs have generally consensus on those patients who do require total neoadjuvant treatment. I think we have come to that stage. As I've given a lot of talks across the country, and speaking to different colleagues in district general hospitals, I think most people now are all right with the idea of total neoadjuvant treatment. But where we find uh, variability is whether some centers actually prefer to go with chemoradiotherapy first and others with chemotherapy. And that is a debate which is impossible to solve because the data are in favor of both approaches. The second issue which also comes to the mind when you're treating these patients is that these days there's a higher incidence of complete response. So the complete response approaches nearly 30% with any of these approaches. And what to do in that situation? Do you actually offer them operation, or do you actually just offer them watch and wait policy? And both policies have their pros and cons, because obviously if the patient hasn't had surgery, there is a trial ongoing at Royal Marsden, but it hasn't yet reported. Although the feeling is that in the end the outcomes would probably be comparable even with watch and wait approach. Nevertheless, the standard of care is still offering them operation. So obviously for younger patients, there's a caveat that you subject them to long-term follow-ups with 3 monthly MRI scans and then sigmoidoscopies, biopsies. So it's some serious undertaking. On the other hand, we know that these operations can be with a lot of consequences. So I think the important thing is having the awareness what the standard of care is and what the options are, and then discussing them in an informed fashion with the patients. Where circulating tumor DNA is important is that we hopefully will come to a point where patients who are going on watch and wait policy could have circulating tumor DNA. And if that in fact shows negative data at that time, no detectable mutations or no circulating tumor DNA, then you can be more reassured that the risk of relapse in those situations is lower. So I think that's one of the ways forward, and I'll be talking about circulating tumor DNA later. So the conclusion from TNT is that consensus is oddly lacking. Okay, patient preferences and careful discussion in MDT is of pivotal importance. And I think the patient discussion with the patient is the most important aspect, but it should be unbiased, because obviously we know that patients are more likely to follow the pathway that we offer to them. So therefore, it's important that we give them a very neutral opinion about what the options are. For high rectal tumors, CT2, T3 with nodal involvement, neoadjuvant chemotherapy should be considered. In my view, it is highly likely that CRT can be omitted because these are less high risk tumors, but you can achieve a very good response. Low rectal tumor, which are CT3, CT4 with high risk features, again, TNT should be strongly considered and recommended. If patients are symptomatic, in my view, chemoradiotherapy should be offered first. Symptomatic means very heavy intermittent PR bleeding. Most patients would have PR bleeding, but if they're troubled with that, or more importantly, rectal pain on defecation. So those patients clearly need management of the localized symptoms first. To be fair, that is less common actually, and that's the reason why these patients present with bulky tumors, because they're less symptomatic for a period of time. So therefore, for most patients, in my view, chemotherapy first can be offered with a low threshold to switch the treatment if necessary. So far, I've treated probably around 50 to 60 patients in NHS and private sector combined. And there was only one patient for whom we needed to organize an emergency operation because they had complications following chemotherapy. But otherwise, this approach has worked very well. ctDNA, where possible, can help in management of these patients, particularly in terms of choice of chemotherapy. Remember, when they finish, so my approach generally for these patients is they have FOLFOX 6 cycles, then they have a little break, they have scans, then they have chemoradiotherapy most of the occasions, then they have 6 weeks break, they have further scans, then they go for surgery, and then they come back for another 3 months of adjuvant chemotherapy. So these are high risk T4N2 or T3N2 patients with CRM threatened. So far, the evidence suggests that we rely on the preoperative staging. So even if they have a fantastic response, I tend to rely on the initial staging of the tumor. So if they presented with T4N2 disease, and even if they have complete response, pathological response, I would still go and offer them chemotherapy based on their initial staging. So this is an example of a patient, so which is where patient preferences are critically important. This is a man who's actually a BBC presenter. He made it very clear from the beginning that he didn't want surgery, even though for him it was our strong recommendation because he had baseline rectal tumor with mesorectal nodes, you can see. So quite bulky disease. He had 3 months of neoadjuvant chemotherapy and he had a partial response to the treatment. And then subsequently, he had almost complete response after chemoradiotherapy. Now he decided against operation. And in this patient, what we did was we gave him the remaining 3 months of adjuvant chemotherapy and then did his scans. And even that residual disease disappeared. He remains in complete metabolic response and complete radiological response a year later. Now, coming back to the same thing, what we are going to touch upon now is the ctDNA background and applications. So the question is, should liquid biopsies enter clinical practice and how should it guide the management? I think I might have spoken to you in the past and shown you this, but it is an important study which is highly quoted. Thankfully, this has received almost 1,500 citations so far. So I'd repeat that just to revise the concept how the liquid biopsies are important and how they can make a difference to the outcome of the patients. So we designed this study a few years ago. We had metastatic colorectal cancer patients for which we had diagnostic samples available. We offered these patients third-line anti-EGFR therapy, cetuximab. The good thing was it was not combined with chemotherapy, so we had very clear signals when we took the biopsies, both liquid and solid biopsies. These patients had tissue biopsies at the baseline, at the time of partial response, and then at progression. And we had 4 weekly liquid biopsy samples. Important thing was that the liquid biopsies at the time were not standard of care. They still are not, but at the time they were not even very popular. So what we did was we did 2 different techniques. So we ran ddPCR, which is a highly specialized technique, 1 in 10,000 sensitivity. And then we ran another technique, which was deep NGS, which has 1 in 100,000 sensitivity. In parallel, we did whole exome sequencing as well, which was just 1 in 100 sensitivity. So there were 3-4 different techniques with variable sensitivities that we applied. So first thing to notice here is the intratumoral heterogeneity, as I alluded upon earlier. So this is really fascinating stuff. So you see that segment 2 liver lesion in this patient, which we biopsied at the time of progression. Segment 4 liver lesion, we also biopsied. So 2 separate lesions were biopsied, and we had obviously the primary sigmoid cancer tissue available. What you see here is actually in the most right column where it says primary sigmoid cancer, there was no mutation in that patient at all. And what you see here is that these mutations evolved over time. In segment 2 and 4, the NRAS mutation, 12C mutation, is present everywhere, although you might notice that the variant allele frequency determined by or demonstrated by the color, the orange color, it's slightly variable in segment 4, where it appears more prominent compared to segment 2. However, interestingly, this KRAS V141 mutation was only present in segment 2 and still not evolved in segment 4. So what it tells you is that even if segment 4 was responding to the treatment, segment 2 would not respond because it has developed a new mutation, which is a new mechanism of resistance. So what we found was that with proper selection of the patients, we could have avoided a lot of patients who were treated with anti-EGFR therapy, because a lot of them had baseline mutations. So you see here that baseline mutations are the red ones. So these are the patients who had very poor overall survival. And those patients who had no baseline mutations, they did very well. Likewise, we had the example of positive selection, which means that a lot of patients had these mutations either at the baseline or they developed later on, and they could have been treated with targeted therapies. We know at the time G12C targeted inhibitors were not available, but a lot of patients who developed G12C mutations could be treated with those inhibitors in this day and age. Importantly, we found that there was high concordance between solid and liquid biopsies if the same technique was applied. So that's the other limitation when we do the solid biopsy. We rely on methods such as COBAS, which picks up the variant allele frequency of the mutations only if there are more than 5% mutant alleles. What we are talking about is highly sensitive techniques. So obviously the field will develop over a period of time, but it highlights the value of sensitive techniques in picking up these mutations. Now, a lot of stuff during that time, not just our studies, but a lot of other studies came from Bardelli's group in Italy and groups in USA. And we all showed that liquid biopsies were a highly reliable technique in terms of picking up the mutations. So these findings now, thankfully, over the last 5 to 6 years have been transformed into clinical practice in adjuvant setting. Why is it important to evaluate the role of chemotherapy in adjuvant setting? We know that in adjuvant setting, even in the most desperate scenarios, T4 and 2B disease, the benefit from adjuvant chemotherapy is relatively modest. 15% we quote, 15 to 18% in some situations, but particularly in Dukes B, the value of adjuvant therapy is truly debatable. It varies from 2.5 to 3.6% depending on which high risk factors you're looking at and which data you're looking at. So the question was asked in this excellent, very well designed study called Dynamic Study as to whether adjuvant chemotherapy could be guided based on the ctDNA findings in stage 2 colorectal adenocarcinoma, which is the more important aspect in terms of determining the need for chemotherapy. So this is the study design. These are the patients with stage 2 cancer who had all R0 resection, good ECOG perform status, and importantly, they had a CT scan within 8 weeks of their surgery, confirming that there was no radiological evidence of cancer there. And then they had, they were offered either treatment based on ctDNA, and the other arm was a standard of care arm where they received chemotherapy. And these patients were closely monitored with CEA, just the standard follow-up, and CT scans. So this is quite fascinating stuff. So what you see is that recurrence-free survival met non-inferiority. Those of you who have interest in stats would know that non-inferiority studies are the most difficult to prove because you need to have high numbers of patients, because what you're showing is that that approach is non-inferior to the existing approach. Superiority studies are easy to organize and they require less number of patients and the statistical considerations are less stringent. So in this situation, what they found was that recurrence-free survival, when it was based on the ctDNA guided management, actually was absolutely identical to what it was without ctDNA guided management. In other words, a lot of patients who received chemotherapy could have avoided chemotherapy if we were guided by ctDNA. This held true for even patients with T4 disease. Now, when we rely on clinicopathological parameters, in Dukes B, the most significant parameter is the T4 disease. But even in that, you see where this is just to show that T4 has quite poor outcomes. So even in these patients, we did not see a difference in the outcomes when it was guided by ctDNA. Importantly, when you even look at the overall survival data, so sometimes you see those effects, but they're not transformed into a significant difference in the overall survival. But what you see here is, interestingly, that patients actually had 5-year survivals which were identical. So if at all, numerically, you can say that ctDNA guided therapy, patients had a 93.8% survival and standard of care had 93.3% survival. And likewise, when you look at the overall survival by ctDNA, it was clear that ctDNA positive patients, which were obviously smaller numbers, remember this is Dukes B, had a 5-year survival of 85.6% compared to 95.3%. So that is understandable because those patients had some form of micrometastatic disease there, and that was picked up by the ctDNA. And now the biological concept. So not just that the ctDNA showed significance, what it showed was that there was also correlation with post-op ctDNA molecular burden and clearance and relapse-free survival. So what that means is that if you have a higher variant allele frequency of the mutant alleles, then your outcomes are more likely to be adverse compared to those who have a smaller mutant allele burden. Likewise, the clearance. So patients who were offered chemotherapy and then the ctDNA cleared, they actually came closer to the baseline. But you'll see that these were the patients in the bottom red graph who actually, despite the chemotherapy, did not have clearance of ctDNA. And that's actually where their mutant alleles persisted, and their 5-year survivals were not so great as those who had the clearance. These are again quite fascinating findings if you think about it. Obviously, that leads us to some challenges. That leads the oncology that invites us to think about what the challenges are. And the challenges are that these are early days. So tracking how many variants is or should be the standard of care. Should we track just KRAS, NRAS, or TP53, or what should we be tracking? And that is something which will evolve over time. So this is an example to highlight where we stand with the trials. So you would be able to not even count how many trials are ongoing looking at ctDNA. And what we see is that they have all different endpoints. So some are treatment de-escalation. I think the treatment de-escalation is probably the safest bit, as was the dynamic study, because what they're looking at is that those patients who are ctDNA negative, they can reassure them. And I've started doing it in my private practice, where patients who come with Duke's B tumors, I do the ctDNA. If it is negative, I don't offer them adjuvant chemotherapy. So I think that bit is pretty much straightforward. Treatment escalation, we have a lot of questions that are unanswered at the moment. Because, for example, you have a patient who is Duke's B and has a ctDNA positive outcome at that point. Do you offer them capecitabine, or you do offer them cape with oxaliplatin or 5-FU oxaliplatin? Do you offer them 3 months, or you offer them 6 months? How frequently you check the ctDNA? These are the questions which are unanswered in the light of evidence at the moment. So then there are questions being asked in these different panels and different trials, where they're looking at, for example, NGS panel. Should it be a 30 genes panel, 50 genes panel, 5 genes panel, or ddPCR, which I mentioned we use that technique, but that's a highly sensitive technique for specific mutations. So you can't have a broader panel with ddPCR. And then there are methylation ddPCR assays. So lots of things which are still unanswered. But I think the important thing is that if we go back to the research, you will recall some of us who were going through our training or were already consultants were seeing that there were these things called CTLA4 inhibitors, which are coming into clinical practice. And at that time, there was no framework of what the outcomes would look like for renal cell carcinoma or for melanoma. We didn't know what the management of the toxicities would look like. I still remember the first time we were trained about the toxicity management, we were told that if somebody has diarrhea, stop the treatment straight away. Okay, so I think what I'm trying to say is that we don't need to worry about how the research would evolve. This is actually a stepping stone in terms of positive management of our patients in future. And this will evolve because there are so many trials will come to the conclusion. So for ctDNA part, my conclusion is that more mature data from dynamic study will confirm ctDNA approach and have confirmed ctDNA approach in Duke's B colorectal cancer should be used and considered where available. ctDNA clearance can be achieved in high proportion of patients and is associated with favorable outcomes. Duke C, at the moment, there's no convincing data. So what I would say is that if you're in the private sector or your patient asks you if they can go for ctDNA, you should still be offering them at least 3 months of adjuvant chemotherapy. And then at that point, I think it would be reasonable, particularly for high-risk patients, to have a ctDNA test. And then you decide between 3 months versus 6 months. And this is again a case of rectal adenocarcinoma. And here I want to highlight that we can always extrapolate the data and use the evidence available in the light of science and the robust evidence. And that's critically important. I'll give you this example. So this patient actually is a young patient who came to me some time ago, had widespread liver metastases. You can see he was 27 at the time of diagnosis. and he had a rectal primary which was bleeding. So his hemoglobin was 60 when he presented. We did all the tests. He was RAS-RAF wild type. This was almost 5 years ago. It's a long story, but he came NHS and then was treated in the private sector. I sent a foundation medicine test, and that demonstrated a rare poly 238 mutation, which is rare, but there were few case reports of uterine cancer patients who had complete response to immunotherapy. I made an application to his insurance company, who initially rejected because there was no evidence in rectal cancer. I collated more evidence and wrote them a scientific note, almost like a paper, telling them that they needed to approve it because there was strong enough evidence that this patient could be cured. So he had a few months of 3 months of immunotherapy with excellent partial metabolic response. Then he had further response. Then you see the tumors almost disappeared. This is in the liver, January 2022 virtual CMR, and complete metabolic response. Importantly, you see some spots there. It is critically important for everyone who's managing patients with immunotherapy. If you find these spots and the radiologist reports suspicion of relapse, always think about biopsying any nodes, not just in the chest. This is sarcoid-like reaction, but I've had patients who had a convincing report by very senior radiologists suggesting that this patient has a retroperitoneal lymph node, which is now 1.5 centimeter. It's lighting up on the PET. And the MDT recommended we should switch the treatment, but I insisted that we needed to do a biopsy, and the biopsy came back negative. So it's important that before you make the decision, always make sure that before switching the treatment, you're 100% confident that there is widespread or convincing evidence of metastatic disease. So this patient remains in complete metabolic response as of October 2024. So point I was trying to highlight here was that if you go by traditional management of the cancers in the light of evidence, there is no phase 3 data to show that poly mutation patients would benefit from immunotherapy. And there would never be such data, because even if you screen every patient firstly, not patients are screened for poly mutations, but let's say we start screening everyone for poly and POLD mutations. The incidence which is reported is 1 in 200. Some literature suggests 1%, some suggest 0.005%. Either way, how would you design a clinical trial, phase 3 trial, which is powered enough to look at polymutant patients? Because what you need to think about is this trial design would normally require 200 to 300 patient minimum, one arm with standard of treatment arm, second arm with immunotherapy. So when would this trial finish? During that time, hundreds of patients will die, okay, because of the inappropriate treatment. And secondly, how would you justify ethically offering standard chemotherapy to the control arm in that trial? So the thought process that I wanted to provoke through this talk was that, yes, we have to stick to evidence-based medicine, but I see all the time, sometimes even in our discussion groups, where people are too much driven by evidence. Evidence is important, so don't take me wrong, evidence is really important, but there comes a point where you need to think a little bit outside the box, still in the light of evidence. So for example, the incorrect thing would be somebody says, oh, immunotherapy is brilliant. Even if there is no POL-E or POL-D mutation, TP53 mutation, I want to try immunotherapy. That is not sensible. And I know nobody would do that, but it's just to give you an example where you draw the line. On the other hand, if you have a strong oncogenic addiction principle, which means that you're aware that there are certain genes which would almost guarantee response to the treatment in other tumor types. So for example, as I said already, MMR deficiency. If MMR deficiency is in a uterine cancer patient, there's no reason to believe that immunotherapy won't work there, even if there is not enough evidence. I am not following uterine cancer, by the way, but I'm just giving you an example, or any other cancers. So on the other hand, there are some targeted therapies which have modest efficacy or improvement in outcomes, but there is no true oncogenic addiction. So for example, the PARP inhibitors. So PARP inhibitors in ovarian and breast cancer have a lot of success. In pancreatic cancer, there is not enough data, and there is no concept of oncogenic addiction. So you're not targeting a certain genes. You have the BRCA mutation, but you're not using an inhibitor which is actually utilizing the concept of attacking the BRCA. So this is a slightly different mechanism. So I think the important thing is that you do not make those decisions without any evidence, and you do not make those decisions on your own. You must actually go through the MDTs where people can actually extrapolate the evidence and think outside the box. Now, in the colorectal cancer, the most important development in the field has been in colorectal liver metastases. And the question was, can we achieve cure or long-term remission? So colorectal liver metastases can be divided into three categories: resectable, unresectable, disseminated. So resectable patients, very quickly, there was collision trial which was presented. There's often a question asked in the MDT that they're small enough lesions. Would they actually respond to radiofrequency ablation, or should you always offer them resection? This trial was beautifully designed. It looked at patients who could be offered either of those approaches and randomized the patients into two groups. Up to 10 liver metastases were there. And they offered resection versus thermal ablation. The bottom line is it showed no difference in the progression-free survival. I think the important thing is that not in all the centers there might be enough expertise to offer high quality ablation. So you need to make a decision based on your own level of expertise in that area, whether thermal ablation is the right thing or you prefer to send the patient to the local regional center for resection. But as such, in good hands, there is no real difference in the outcomes. Unresectable liver only metastatic colorectal cancer. This was the most important study of this year. I sit on the liver transplant committee of the UK trial, and we are trying to convince them to modify the criteria. However, this trial transplant study actually was based on the pre-existing evidence that the outcomes are poor for patients with colorectal only liver metastases if they are not resected. And in this patient, in this trial, sorry, they included patients who were ECOG PS 0 or 1, had colorectal liver only metastases. There was a central committee which examined the data available and then randomized the patients to this trial. But this, you will see, they had a very flexible criteria. So more than 3 months of tumor control with less than 3 lines of chemotherapy. To put it in perspective, the UK-based trial and the Canadian trial and a US trial have the criteria of 2 years of disease control, which I think is an extreme. In my view, 1 year would be a good happy medium, because less than 3 months or more than 3 months is a very short time period. Most patients would have some control for 3 months, and offering them a transplant is quite a significant undertaking. But what you see is that if indeed they have they receive the transplant, their 5-year survival was 57% compared to 13% in the control group. And when you look at the intention to treat population, it's almost touching 73%. Important thing is that a lot of these patients relapsed, you'll see, at different time points. So it's important to highlight to the patients when you're referring them to the transplant centers or within the trial, which is available in the UK, that it's not a guaranteed cure, but it's very likely to improve their outcomes. Obviously, lots of questions to be answered. How do you deal with immunosuppression? How do you deal with subsequent lines of treatment? So quite a few things which are still unanswered, but very exciting development in the field. This is one of our studies that we published some time ago, and that is to highlight that the initial concept of multimodal management, what exactly it means. So you have a patient who comes with widespread liver metastatic disease and let's say 2 pulmonary metastases. It is very clear that this patient is for palliative chemotherapy. You start this patient on palliative chemotherapy. A year later, they have an excellent response in the liver. Let's say they're left with 2 lesions which are still lighting up on the PET scan. Of the lung lesions, there are still 2 lesions, but one of them is almost metabolically inactive. The other one is still active. What do? If you go typically in the light of evidence, they have extra hepatic metastatic disease. So you leave them be and just carry on with the chemotherapy or switch and swap as and when required. But what we did with these patients was that we offered them additional procedures based on the disease biology. So we offered them radiofrequency ablation, sometimes liver resection, sometimes combination of those. When they reoccurred, we offered them again chemotherapy, or depending on how they presented again, or repeated radiofrequency ablations, repeated operations. And what we showed was that those patients who had more than 3 procedures, they had significantly better outcomes. So if you look at these graphs, you see that these patients even survived beyond 5 years and had excellent outcomes. And that is not to again say that you offer everybody everything. I think again, it's a matter of sensible decision making based on the disease biology. So you can have a BRAF mutant patient where you can draw the line from the beginning. You know that it has aggressive disease biology, but there are variants in that field as well. I've got a patient who is in the private sector, has been on different lines of treatment and different surgical options we've offered to her over the last 5 years. So she has survived with metastatic disease for more than 5 years. So that was the main aspects of the colorectal cancer. Now I'm going to touch upon, I know some of you might have interest in upper GI cancer, so I'm just going to touch upon the biliary tract cancers. I think we have probably 5-10 minutes. If everybody's all right and you're not too bored, we can go through that as well. So biliary tract cancer is a really important global health problem. And I say this because you'll see that it was considered to be one of the rare cancers. So it was actually considered as a rare cancer within that rare cancer group. However, one thing which is not taken into account is how bad the outcomes of these patients were. A lot of your young patients, those who treat upper GI cancers would know, or hepatobiliary cancers would know, that they present with uh, biliary tract cancers. And the most important aspect is that those of you who treat CUP, 20% of these patients who are considered CUP actually have biliary tract cancers. And the striking data set also shows that a significant proportion of these patients present to emergency medicine department with an acute emergency. So no diagnosis, but direct diagnosis through emergency medicine. We know in the UK and Europe that those patients who present directly with emergency presentations have really dismal outcomes. So that's why it is a big health problem and it is often understated. The other important thing is that there is a vast amount of development in the field. So we now know that immunotherapy has become standard of care. There are at least 2 trials showing that pembro in combination with gemcis or durvalumab in combination with gemcis improves the outcome. So you have Keynote 966 and Topaz 1 trial. Both of them confirmed the evidence in favor of the immunotherapy. So we actually looked at again at our data set because we have a big data set because we are tertiary referral cancer center, and we looked at our outcomes. So firstly, a lot of patients are referred to us. Sadly, a lot of patients are told when they are referred to us for second opinions by their primary centers that they're not for any systemic treatment, and that includes a lot of young patients. So we found that 30 to 35% of the patients who were told in other centers that they didn't have any treatment options, they received treatment with us and they were included in that data set. So this is the data set of patients who were treated at University College London over the last few years. And they had different lines of treatment. So it's about 56 patients who received targeted therapies. This was their genetic landscape. All of them had different genetic tests such as foundation medicine. So as expected, although not at that time, the FGFR story was not so popular, but we found that a significant proportion had FGFR amplifications, and these are all the other mutations which were found. And these patients had a median overall survival of 29 months, which is comparable to any other cancers with metastatic disease. And median PFS, first line, second line, third line, still remarkable numbers, given that these were metastatic disease patients who had progressed straight on first line of treatment. And this was the median duration of benefit on different lines of treatment. Again, it was to highlight that those who received targeted therapies had understandably better outcomes. So this is an example of a patient who was referred from another center, was told that they were not fit for any treatment because they had biliary obstruction. So first we got them admitted, got the biliary obstruction reversed after a lot of efforts. The patient was an inpatient for nearly 6-7 weeks. And then we started the patient on, so she was not fit for anything because of everything that she'd been through, but luckily had actually an FGFR2 amplification, went on futibatinib, and that had gross regression of the tumor. 27 months later, she's still alive and healthy. So when we looked at the second line targeted options in survival outcomes, again, those who received the targeted therapies had significantly better outcomes. Likewise in third line. And what it is highlighting is that when you're looking at the targeted treatments driven by a molecular aberration, patients can have excellent outcomes even in subsequent lines of treatment. The general concept is that patients actually over a period of time when they go on second, third line, fourth line treatment may not respond to therapies because of various selective mechanisms of resistance due to previous therapies. But when you have a driver mutation, even in second, third line, fourth line setting, if patients are fit for treatment, they can demonstrate very good response. Now we know that there are many actionable mutations in cholangiocarcinoma. We know that the IDH1 mutation inhibitors are now available in the clinical practice. FGFR2 fusion or rearrangement inhibitors are available, and lots of trials are examining other mutations. I will now very quickly go through these slides and then we'll stop and we can go through the questions and answers. But IDH1 and 2 are important. We know that ivosidenib is available in the clinical arena now, and you just need to do a CDF form. And we also know that IDH1 inhibitors lead to significant improvement in survival. FGFR story is attractive. There are now, in fact, significant developments in the field. Those patients who progress on FGFR inhibitors, there are second generation FGFR inhibitors which can be offered within the context of clinical trials. And those are fascinating findings. Let me go through these very quickly, but just to show that those patients who had FOLFOX alone, the survival advantage was negligible. Those patients who go on IDH1 inhibitors, you can see a clear survival advantage. Even BRAF V600E mutation, which is associated with adverse outcomes in colorectal cancer, these patients do pretty well on that, and their overall survival was 14 months. And when they go on fujibatinib or pemigatinib, the survivals are 17 to 20 months, and that is in those lines of treatment. There's another HER2 inhibitor, zanditumumab, which is in development, dabrafenib. So lots of developments in the field. How would the future look like? So firstly, we just recently published this paper which summarized actually the ongoing trials. And I'll just not go through each of them, but I think the important thing to highlight here is that cholangiocarcinoma, like melanoma or some of those cancers which were not considered to be attractive specialties a few years ago, has transformed itself into a very attractive biological specialty where a lot of developments are ongoing in the field, lots of phase 1, phase 2, phase 3 studies ongoing. So, HER2 inhibitors, TROP2 inhibitors, FGFR inhibitors, VEGF inhibitors. So you can see multi-kinase inhibitors and FGFR1 to 3 inhibitors, PAN inhibitors. So there are lots of things in the pipeline. This is a diagram that we recently came up with, and that shows how outside the cell we have so many targets available. So you have FGFR2 pathway, you have HER2 pathway, you have receptor tyrosine kinase, you have the dabrafenib, trametinib, or other BRAF inhibitors. You have the IDH1 pathway, which is also targetable in these cancers. Why it is important, targeted treatment approaches: they improve treatment response rates, they have manageable treatment, the toxicity profile, they have better outcomes, they improve quality of life, and the patients can have a retained PS such that they can have further lines of treatment. This to me is the most exciting concept. Again, we published this recently and came up with this diagram. What it shows is that when you're on a pathway inhibitor, it does not stop you from improving your knowledge and understanding about those pathways. So you've targeted that. We've learned it from the lung. So you had that EGFR mutation, you had an EGFR inhibitor, then you went on to that resistant inhibitor, then you're developing more and more in the field. Likewise, you can have either polyclonal resistance or the pathway resistance. Pathway resistance is where you have, for example, targeted the FGFR and a new variant of FGFR comes and you target that through another drug. Polyclonal resistance is more difficult to treat. So you're treating actually somebody with an FGFR inhibitor, and they develop, let's say, an IDH1 mutation. So outside that pathway. So, however, what it tells you is that you can always actually consider inhibitors in the second line, third line setting. It expands the treatment options that you have when patients are treated with targeted therapies and there is ongoing development in the field. So I think what the future would look like, the biliary tract cancer patients, unresectable or metastatic, will have sequencing, hopefully. Those who have no targetable mutations will receive the standard treatments. And then I would feel that they should, so this is the current ESMO guideline, but what I feel is this is the way it should look like. So sequencing of the samples at the outset, then if no molecular targets, they receive the standard of care. If there are potential targetable areas, then they should probably in future be offered licensed therapies. And then they switch to the Gemcis or durvalumab standard combinations. And then again, this should be revisited at each time point in case they've developed a new resistance mechanism or a new mutation that could be targeted. And this whole sequence should carry on either with liquid or solid biopsies until progression, until the point they're not fit for treatment. So this is an example again of a different patient. This is one of my patients who a few years ago presented with widespread cholangiocarcinoma, widespread metastatic disease, lung, liver, everywhere, lymph nodes. And I did the foundation medicine. She had MMR deficiency. And this patient actually 5 years down the line, I'm just quickly going through that, multiple scans, remains in complete remission. So with that, I'll bring you back to the initial discussion about multimodal treatment and personalized medicine, complementary and or incompatible. I think the key to that discussion is understanding and knowledge about the biology and clinical evidence. And most importantly, a good functional multidisciplinary team and redefining the evidence-based medicine. I think in the interest of time, I had a few other cases, but we can stop here and start the discussion. Thank you very much.
Thank you so much, Dr. Khurram. Excellent talk. I know these are very vast subjects, but you really summarized very well. So I think we have few questions in the box, and I can just quickly go through. Dr. Jahanzeb asked a couple of questions. If you can read it, can you see those questions, or should I read it?
Yeah, let me just have a look at it. So the question about the Lynch syndrome, particularly for detecting early stage cancers on monitoring for recurrence. This is an ongoing field. Obviously, there are lots of studies looking at the early diagnosis in patients. And Lynch syndrome, of course, there is a Lynch Society in the UK as well, Jahanzeb, so I'm sure you're aware of that. The ctDNA is still not standard of care. So I think in terms of whether this would become a standard of care in future or not, whether we can use it or not, the answer is yes. So of course we can use it, and of course it gives us very valuable information. But what is the current standard of care? The problem is we don't have enough evidence to say that, for example, a patient whose family is a Lynch family, can we rely on ctDNA as a screening tool? I don't think we are there yet. But in future, hopefully we will get there. Yeah, so the other question that Hamad has asked is about following TNT, whether we offer them treatment or not. That's the first question. And then other question is your experience with SBRT for oligoprogressive liver metastatic disease rather than opting switch targeted therapies. So the first question actually is the one that I initially addressed, but just to recap, there's about 30% chance of complete response to TNT. And I think at that point, they merit a discussion as to whether they wish to proceed with surgery. And they need to have a discussion with the surgeons as well, because if it is a low rectal tumor and the patient would end up with a permanent stoma, then of course, for those patients, it could be a lifelong impact on their quality of life. So they need to have a clear discussion with the surgeons what that stoma is, how long it will stay for, would it be reversible or not, all those questions. However, if they decide to go with watch and wait policy, then they require intense monitoring. So that's the other aspect that needs to be discussed with the patients. So the answer is yes, they can go on watch and wait policy with the knowledge that the current standard of care, gold standard, is still surgery. But in a lot of centers, we now actually offer them watch and wait policy. And they need very strict monitoring, 3 monthly scans, MRI scans, and then 6 monthly colonoscopies or sigmoidoscopies with biopsies. SPRT or stereotactic radiotherapy, indeed, we use it very frequently. We are one of the SPRT centers. Again, it has to be rationalized. So, for example, you have a patient who had initial presentation with metastatic disease, and I have a few of them who had very good disease control for 18 months, 24 months, and then they have a single oligometastatic lesion. So yes, indeed, SBRT or sometimes radiofrequency ablation, and that's a debate in the MDT, which one is considered to be a preferable option. So for example, if they have a retroperitoneal lymph node, it's it's a difficult position, but with in good hands, the SBRT is probably a preferable option, or a lymph node in other areas. On the other hand, if it is actually a liver lesion which is easily ablatable, then that would be probably the preferable option. There's no study to distinguish between SBRT versus radiofrequency ablation, but you make a rational decision based on the disease biology, anatomy, and other things. Then there's a question about the vaccines in colorectal cancer. So indeed, we are setting up. So there are a couple of trials that I've set up actually, which will hopefully start recruiting in near future. There's a BioNTech vaccine which will be used in the adjuvant setting in colorectal cancer. Is a similar vaccine which is being evaluated in pancreatic cancer. I think Birmingham have already opened that trial, and we are in the process of opening. I'm the PI on that trial. So yeah, I mean, again, very interesting developments. My own feeling is that in next 5 years, indeed, mRNA vaccines will be considered, if not standard of care, but very important considerations in some of these cancers.
Right. So there's one more question from Dr. Jahanzeb. I'm not sure. Is it possible to measure ctDNA levels after neoadjuvant chemotherapy, but before surgery, to detect minimal residual disease and guide decision about proceeding with surgery? I think it's there. You can see the question there. Yeah.
So with regards to ctDNA, one of the important things is that post chemotherapy, ideally you should have at least 4 weeks break, because when you're actively on chemotherapy, you may not detect enough circulating tumor DNA, and that could be misleading. So the answer is yes. So it can be done theoretically, but again, it's not standard of care at the moment. And the difficulty at the moment is that, so we again need to think about how this all will come together in the light of evidence. Because if you, for example, have a patient who has really good response, but on MRI scan, they still have significant residual tumor, but the ctDNA is not picking up anything, then the question is that, do you have sufficient evidence at this point to say that, okay, we are not offering them chemoradiotherapy and surgery because they are ctDNA negative? The answer is no, because this is a long-term impact on this patient. If for example, for technical challenges, the ctDNA was not detected, then they could have adverse outcomes as a result of that. So with the current knowledge, we still need to go by the standard of care. But on the other hand, if they have complete response, and then you do ctDNA and it aids the management, because then you can say, okay, you have actually radiological response as well as ctDNA clearance. So it is safer in this situation to watch and wait. Then that makes sense even with the current evidence.
Um,
Thank you so much, Dr. Khalik, if you allow me. I'm Dr. Zafar Ali from
Yeah,
Castle
sure.
Hospital. So, first of all, thank you so much. That's a very great presentation overall. So, two quick, I need one comments or one other questions. Regarding liquid biopsy, we are dealing nowadays the lung cancer. So, the lung cancer, especially, we have very scanty type of sample sometime, and we do the biopsy and do biopsy. So, did you think I understand the colorectal cancer, they are doing this one on, and you discuss about your some of paper for that. So what would be the good time actually to do the liquid biopsy? Can we start from the diagnosis or it between the time or re-diagnosis, or what would be the good time for do the liquid biopsy? Yeah.
Okay, so that's a very good question actually, because so the and that is somewhat linked to Jahanzeb's question as well.
Yeah.
The timing of liquid biopsy is critically important. If you want to start a patient on chemotherapy, the most important time to do the liquid biopsy is at the baseline before you start the treatment, and that is one of the most important considerations for my private patients, because I do liquid biopsy for all patients with metastatic disease. And what we try to make sure is that before the first cycle is delivered, the sample is taken.
Okay.
Because then you're at risk of subjecting the sample to a lot of complications. I mean, you can still have a positive liquid biopsy after the chemo, but then the timing becomes very difficult, especially in patients who are on ongoing chemotherapy. Because remember, I said ideally you need to give them 4 weeks break. So, for example, you started somebody on FOLFOX, and then you want to do the liquid biopsy, then you need to delay the chemo for 4 weeks in order to do the sample. So you somehow miss the boat if you haven't done it at the baseline. At progression, again, it is fairly reliable, because why, if you think about why progression has happened, of course there are cancer cells which are progressing in different areas, and that is being demonstrated on your scans. So even if they had recent chemotherapy, that becomes a little bit immaterial, although you still try to at least give them 2 weeks break or something from the previous chemo, which is a natural thing anyways, because for most patients, if they had the last cycle of, let's say, FOLFOX or FOLFIRI or whatever, then you wait for a couple of weeks before you do the scans anyways. So so that time is taken into account. So liquid biopsy is reliable at that point as well. The liquid biopsies whilst on treatment is an evolving field, because if you're using very sensitive techniques, then you do expect the liquid biopsies to remain positive. They're positive, like when we're looking at the ctDNA clearance. But then you need to rely on very sensitive techniques, which are not always commercially available. The commercially available techniques at the moment are Foundation Medicine and Guardant 360.
Right.
And
So,
one quick, just a second one. You have one of slides is showing the KRAS pathway sequencings. And one of the genes they mentioned here, the KRAS G12C. So are you having some targeted using in G12C in your colorectal cancer? Because in the lung cancer, we are the nice approved sotorasib we are using for this target. So are you using something for?
Yeah, we have sotorasib and adagrasib in combination with cetuximab. They're still not licensed, but within the trial, actually, they've already shown positive evidence. So you can access them through the compassionate access scheme or through clinical trials.
Okay, because in the lung we are using, and it is already in a nice approved actually. So we are okay. Thank you.
Shoaib wants to ask one question. Shoaib, can you unmute yourself and ask question?
Yes, please. Thank you so much, colleague. Thank you so much, Dr. Khurram. Very nice presentation. I have little confusion about TNT. You described that you start with FOLFOX for 6 cycles. That's 3 months treatment. Then patient go for chemoradiotherapy, then for surgery, and then you mentioned another 3 months of FOLFOX. So basically, my understanding was chemotherapy role in rectal cancer has been taken or extrapolated from colon cancers, and that is only 6 months perioperative chemo duration. Now, when we come to non-metastatic rectal cancers, so 2 months are roughly taken by chemoradiotherapy, and there's 4 months of treatment as mentioned in German rectal cancer trial. And TNT understanding is that total new adjuvant therapy. So that means roughly 6 months treatment before surgery. So what you described, this is around 8 to 9 months perioperative chemoradiotherapy treatment. So is there any evidence for that to treat them around 9 months of perioperative chemoradiotherapy?
So the trials that I showed you, if you look at the Prodigy study and the other trial designs, and then extrapolate the data from the colon cancer. So you're right, we extrapolate the data about adjuvant therapy from colon cancer. So I'm talking about high risk patients, so T4 or N2 patients. So for
Yeah.
those patients in colon cancer, the standard adjuvant treatment is 6 months. Yeah. So with Folfox.
Yeah.
So when you look at the total duration of you're obviously adding the chemoradiotherapy in the whole scenario, and I agree that it is a long treatment pathway. That's what you need to counsel the patients about. But the actual perioperative chemotherapy is 6 months still, not more than that. So you have 3 months beforehand, and then you have chemoradiotherapy, surgery, and then 3 months afterwards. So the problem is that sometimes in some centers, the capecitabine, which is given with radiotherapy, is also taken into account, and some centers argue that we give, 6 weeks less in adjuvant setting. But we know that the capecitabine dose used is low dose, and that is as a radiosensitizer, not as such as a chemotherapy agent. So again, this is all extrapolation of evidence. There is no direct trial answering this question as yet, what is the optimal treatment? But when we rely on the initial staging, and if there are high risk features, and then you combine all the trials that we have seen today, the general consensus is that the chemotherapy requirement is 4 to 6 months in all those trials. So whether you give them FOLFIRINOX initially, that was 9 cycles. So roughly you're looking at 4 to 6 cycles, 6 months of chemotherapy. So the scheme that we've come up with actually, in a nice way, takes everything into account. That you have, you're following the high risk features from colon cancer, so you're offering 6 months of total chemotherapy, and then you have obviously the luxury that in patients. So what we also tend to do is with the neuropathy, we know that a lot of patients struggle. So the last 3 months, which is adjuvant treatment, I tend to be more flexible. So if I need to drop oxali, I have a low threshold to drop it or reduce it or omit it altogether, or even stop chemotherapy if necessary. But if your patient asks what is the maximum benefit I can achieve in a super fit patient, young patient, then I think that with the current evidence, you do need to consider all of that.
Yeah,
But then,
I agree with you. Just to add one thing, Shwet, like Rapido trial, they gave all the chemotherapy up front. But if you talk about Prodigy trial, when you treat this patient on those trials, so you have to give neoadjuvant as well as adjuvant chemotherapy. So neoadjuvant chemotherapy usually is for 12 weeks in Prodigy trial. Then you give long course chemotherapy, and then you give another 8 weeks of adjuvant Folfox or Capox. So it depends how you're treating the patients. I agree with Dr. Khurram. So yeah, go ahead with the next question now. Yeah.
okay, thank you.
Right. Okay. Any more questions, anyone? Looks we don't have any more questions. So thank you so much, Dr. Khurram, for your time, and really appreciate I know it's a weekend, and thanks everyone who participated in the discussion and sparing the time to attend this fruitful meeting. I hope this will help a lot in the practice, because this was very, very practical presentation. So thank you once
so
again.
much. It's
Thank
very
you.
kind. Thank you very much.
Okay, then thank you everyone. Take care and have a
And
good
at the
weekend.
end, I will ask thank Dr. Butt actually to arrange all these lectures series. Is very
Okay.
excellent series. I really appreciate Dr. Butt for you and arranging all the things. Really,
That's
thanks
right.
so much.
Yeah, we really appreciate everyone who participated here, and of course the organizers in the background who are working very hard, and the presenters, of course. Okay, then. Thank you so much.
Bye-bye.
This will be the last session. Sorry,
Yeah.
this will be the last session. So we'll be again coming back with some other international meeting. The colleagues who go there, who haven't presented, will go there. Just keep in mind that we'll be asking you present it in future.
And
Many
that's
of you will.
just to say, fascinating background, Butts up. So We should be invited there.
But sir, in the beach actually.
Yeah.
You're more than welcome.
Yeah. Okay.
It's bit cloudy today, but you're more than welcome.
Okay.
Okay.
So
Thank you so much.
Thank you, Khurram. Thank you very much for coming along, and we'll see you again, hopefully, for the meeting for launch of the BPC at somewhere in January, 25th of January, I think it is, in Manchester. So we'll be getting back to you with more details about that.
Inshallah.
Thank you so much.
All right. Thank you, everyone. Have a good weekend. Bye bye.